So good day. Thank you, Francesco, for inviting me. I have the pleasure to talk about the potential of the MS-39 topographer in multifocal intraocular lens selection and its associated limiting factors. And I come here from Vienna because, as we know, cataract surgery nowadays is no longer just a therapeutic procedure. It's effectively morphed into an intraocular refractive surgical procedure, mainly due to many improvements, but also due to the plethora of intraocular lens designs that are available nowadays to treat presbyopia. And this is also relevant for patients when it comes to refractive lens exchange, clear lens exchange, that are being employed before the onset of cataract. And corneal tomography/topography is crucial for lens selection, obviously, as we previously discussed, particularly when it comes to refractive cataract surgery. So as we already mentioned, the MS-39 is a spectral domain OCT device combined with placido for the anterior surface of the cornea. And it has very high resolutions of excellent transversal resolutions, especially compared to other commercial OCT devices. We at our clinic, we have been using the device for like 2 or 3 years at this point now. We're very satisfied. And we always employ a standard scanning protocol. I know we can customize this slightly, but essentially that's the way we measure patients. And here I want to go more into detail when it comes to the corneal wavefront analysis input. So when it comes to corneal aberrometry, you basically want to optically characterize corneal shape irregularities, even more subtle ones, iota aberrations, not just limited to astigmatism, for example. And this is insofar crucial because the optical quality of the cornea will, of course, be coupled to any given lens design that induces multifocality or depth of focus, but also obviously when it comes to employing the when it comes to ray tracing and non-paraxial ray tracing. And the MS-39 has with the Phoenix software version 4, we employ basically into the eye ray tracing. This is, as Giacomo already said, a physical principle to also, when it comes to tomographic data, derive clinically relevant aberration parameters. And of course, this is relevant because any sort of corneal optical tomographic data will be coupled to a given lens design, which will then essentially form the retinal image, right? So if you know the spatial dimensions of the eye and you would know the geometric properties of a lens, you can at least hypothetically predict outcomes. So we published recently basically a comparison of the MS-39 against the Heidelberg device for the corneal aberrometric components, so anterior, total, and posterior curved aberrations. And as you can see here on the top left side, you would have the anterior contributions, in the middle the total, and very negligible the posterior ones on the bottom left side. And if we convert this into a more standard dioptric vector space, as in the upper right, the Zernike astigmatic terms, you get something that is very well published, where you have a more even distribution of with the rule and against the rule astigmatism for the anterior cornea, but then the posterior cornea is usually always on the 0-180 meridian. And this is insofar relevant because, number one, it compares well to other aberrometric studies in younger patients, but number two, cataract patients usually have higher amounts of iota aberrations than younger patients. This is something that's not unexpected because the cornea becomes less regular, age-related. But it's also relevant because from a certain threshold onwards of root mean square high iota aberration, this will equal a 0.5 diopter blur and will, according to some accounts, could represent a relative contraindication for multifocal intraocular lens implantation. And this was the case for 70% of patients in our study cohort. So these were nominally normal patients without prior refractive surgery, without any sort of history that would be notable. Because this was mentioned before, the corneal sphericity, this is also obviously relevant for a specified zone, because we know we have nowadays usually mostly aspheric lenses that are designed at fixed amount to compensate for the naturally positive corneal spherical aberration and enhance the image quality for the patients. And this corneal spherical aberration exhibits to some degree some variability. So it will be prudent to tailor this to an individual patient. And there's also nowadays the newer lenses. I mean, newer. They've been quite for some time now, but they all essentially play with spherical aberration to induce the depth of focus with different orders of aberrations to enhance or alleviate presbyopia. And lastly, as previously mentioned, post-refractive surgery patients will have an altered cornea, which will obviously depend on the initial condition. And I'm telling you all of this because we have actually some data of these lenses, some aberrometric in vitro data. On the top left, you can see some of those lenses that are usually commonly being employed. Some of them quasi-exclusively induce negative spherical aberration. Others, so for example, the IHANS is a negative spherical aberration inducing one, whereas the RENA EMV is a positive spherical aberration inducing one. And this obviously, when you couple this to the corneal optics, to the spherical aberration, you'll have a certain amount of variability between patients. So this is oftentimes treated as a fixed value, but actually, depending on the patient, this might not be the case and will alter the predictability of depth of focus extension and also visual quality. So because all of these lenses essentially they reduce contrast sensitivity one way or the other. Another aspect is of course screening for multifocal or diffractive EDOF IOL patient or candidates, because these lenses essentially all redistribute light for different ranges of vision, which invariably go along with the reduced contrast sensitivity, right? So compared to a monofocal, you have many different focal points. Here on the left side, you see sort of the point spread functions for far, near, and intermediate focus. And on the right side, you see like a longitudinal scan, basically, where this will be the retinal image intensity at 0 diopters, and then at 1, 2, 3, depending on lens design, of course. And we all know patients who have nominally a high visual acuity of 20/20, but are yet still unhappy with their visual quality. And these patients who have such implants have obviously are less tolerant even to minor ocular aberrations, not just residual defocus or astigmatism, but also high order aberrations, decentrations, and then coma, so on and so forth. And also what's worth mentioning is that in addition to the aberrometric profile of the cornea, you would also like to have a normal pupil size that is within a normal range to avoid halo glare and dysphotopsia. Now, this depends obviously on the patient demographic. Younger patients have bigger pupils. The cataract surgery demographic usually has a senile meiosis. So this is something that will probably not be that relevant. Screening for tear film integrity, you can do that with the Placido nicely. Placido is sensitive to tear film irregularities, but I think tomorrow there will be an in-depth talk about this. But now I also want to go or to explore some of those limitations because they're all related to the potential of ray tracing, but also some inherent fundamental obstacles or barriers which hinder the improvement of refractive predictability. So this is for normal eyes, not post-surgical refractive eyes. And as Giacomo already previously explained, the prediction of the lens position is the foundational error, the main source of error contribution to any lens power calculation formula. But the second biggest source on average is also the post-operative refraction itself. So there is post-operative refraction variability which these formulae are optimized for. And so this is also something that will hinder the improvement of the refractive predictability no matter what you do. The precision when it comes to corneal aberrations has been already published for the MS-39. I know this is a boring topic, but basically what I want to point out is that usually a 0.1 micron increment is considered to be clinically significant, and the within subject standard deviation is always below that, although the test-retest repeatability is slightly higher. So this is also relevant because when it comes to the Zernike analysis and ray tracing, this usually has stringent data quality requirements. And when you do repeated measurements, this might slightly alter the wavefront. And I really want to point this more recent publication by McAlinton and associates, whereby they show that when they account for tilt and misalignments of aberrations from the pentacam, in this case, the pentacam HD, the zonic aberrations become very precise. So there is inherent also variability baked into the cake when it comes to using zonic polynomials reporting. Then, as Giacomo previously also mentioned, and this is a big limitation, the proprietary data on exact IOL geometries is a prerequisite, and this is usually non-disclosed. Manufacturers don't give it away, so you have to be limited to A constants, for example. Number two, again, postoperative subjective refraction has a 95% spherical equivalent test retest reproducibility of 0.5 to some even say 0.75 diopters, which is also something that is oftentimes overlooked. And although automated refraction is more precise than subjective refraction, it usually has a slight myopic bias compared to subjective refraction, which needs to be adjusted for. Another slight problem is obviously the pupil size estimation or prediction, actually, because there is a bit of a difference between what the actual pupil size is and the refraction corrected pupil size from anterior segment imaging. So this is a bit maybe in some cases falsified, depending on also the refractive properties of the eye. Number two, when you have a placido disc illumination, you have usually photopic conditions due to the bright reflection. But obviously, when you want to then assess aberrations with the infrared device, this will have a different illumination. So this changes also slightly pupil size and situation. And speaking of pupil size, also worth mentioning is that most studies that are being conducted when it comes to intraocular lenses that extend the depth of focus really are being reported at fixed pupil sizes, 6 millimeter, 5 millimeter, and so on. These are not physiological pupil sizes. And so we as clinicians should maybe more look into that to really try to predict preoperatively what actually the postoperative pupil size will be. And lastly, of course, when it comes to ray tracing, this has been known for quite some time now, that not all aberrations are equal. In fact, the higher order root mean square error metric is a very imperfect metric, and it doesn't really translate that well into visual quality. So some aberrations have beneficial interactions, others cancel each other out. And so there's sort of like a bit of a difficulty to translate from optical performance to visual quality. Future outlook would be, so we also believe that ray tracing will be the future, also even for regular eyes. And what would be desirable would be a more comprehensive interlinking between perioperative data, so aberrometric data, biometry, pupil size, and ultimately intraocular lens geometries. Hopefully clinicians can put more pressure on manufacturers to disclose them, because it would improve outcomes, right? Thank you for the attention.